part 4 of headaches of neuro ophthalmic origin. So it's been a while, but I'm glad to be back here interacting with learned colleagues and the audience in general. So we have been talking about migraine. We've been discussing, saying so much about migraine, what it is, and not just migraine, but other forms of headache. But in our last class, we began by teaching on migraine, and then we began to note important and salient points about migraine. So I want to do a quick overview on it, and then I introduce what I want to teach this evening. So in case you are just joining us, you are welcome. Please, I indulge your please subscribe, like, comment, and share. Subscribe on the channel, comments. I want to get your feedback, your questions, your contributions, your observations, whatever it is. I want to get your feedback, and also do well to like the video and also other videos. Also do well to share to as much as you can share. As you do so, you are blessed in Jesus' name. So quickly, we are looking at migraine. We've talked that we've said that it's a disease that causes headache, mostly more prominent in women and higher among those who are 30 to 50 years old. We also say that it is more common in the blacks than in the whites, and we also said in our last class that patients with migraine have a higher risk of having stroke, especially those who have migraine with aura. And we also say that the stimuli to migraine are sensory. They can be auditory, they can be due to sound, light, or smell, but most times the stimuli are sensory. And also certain foods too can induce migraine, such especially red wine, cheese, chocolate, several. So the stimuli or the triggers to migraine are common facts that we can find amongst ourselves. And we'll say that the pain usually lasts for about 4 to 72 hours and is relieved following a night's sleep. We also say that attacks are more common in the day, and also aura is a set of neurological symptoms, usually visual, sensory, or speech related, that accompanies migraine. And we say that migraine can be migraine with aura and migraine without aura. We also say that aura can be divided into two, which is the positive aura and the negative aura. So in the positive aura, the patient is seeing something that is not really there. Example is seeing bright flashes of light, having blurry vision, scintillation, heat waves. While in the negative type of aura, the patient are seeing parts that are missing. Example is transient vision loss, blind spot, tunnel vision, a loss of color vision, etc. So we made mention of all these, and we also began to introduce unusual forms of migraine, and that is where I'm going to be emphasizing on this evening, and we call it a wrap. So apart from the classical migraine we see in the clinic, in the hospital, that doctors encounter, patients are experiencing, there are also other forms of unusual forms or classes of migraine, and I want to dwell more on them this evening. So one of them is the basilar artery migraine. The second is the ophthalmoplegic migraine. The next is retinal migraine. There is complicated migraine. There is benign episodic migraine, hemiplegic migraine, migraneous vertigo, and then there's also migraine in women. So I will just begin to touch on them bit by bit, and then we wrap up migraine and go to another type of headache. Probably I'll begin this class, and in our next class we'll delve fully into other types of migraine. So this is the part 4 of headaches. So just in case you are joining us for the first time, please do well to watch part 1, part 2, part 3, so that you can follow up on what we are doing. And then if you are watching the part 4, you can see the link and understand where we are coming from and where we are heading to. So there is what we call complicated migraine. It is not just the ordinary migraine experienced in the clinic. There is a migraine called complicated migraine. What is this all about? It refers to a permanent neurological deficiency, which can be sensory, visual, or motor in origin. In the normal migraine we experience, it is not permanent. It comes and it goes. The patient experiences it for some, maybe a few hours or probably few days. But in complicated migraine, it is permanent. In other words, it is a continuous type of headache that is always there. So it is a neurological deficiency, and it can be very, very painful and disturb normal life experience. So in this case, when we encounter this kind of migraine in the clinic, we usually send for MRI, magnetic resonance imaging. We usually send for MRI, which will always show cerebral ischemic changes. And before sending for MRI, we want to also find out there are some patients we shouldn't send for MRI. There are contraindications to MRI. For instance, a patient who has had head injury and probably must have been sutured with metals also, you can't send for MRI because there's a metal in the head, so you shouldn't send for MRI. And there are some people who their MRI can even worsen their headache. So we are careful sending for MRI in people who have headache, because the MRI can also induce more of the headache. But then MRI is important because it usually shows cerebral ischemic changes. In other words, blood supply, oxygen supply is low in such areas. We want to know why it is so. So the treatment is usually a high dose of intravenous methylprednisolone. A high dose is usually given, and hydration is employed. So this is usually the treatment plan for such kind of patients. And again, triptan medications are contraindicated due to their vasoconstrictive properties. Triptans are a class of drug we use for majorly treating migraines, but in this kind of migraine that is classified as complicated migraine, triptans are highly contraindicated. So that is that for complicated migraine. The next kind of migraine is the migraine we call basilar artery migraine. Basilar artery migraine. In this type of migraine, the symptoms usually include visual field defects. So the patient is saying he's not seeing something in a particular side of his vision. So this is what we call visual field defects. Another symptom is vertigo. Another symptom is nystagmus. Another symptom is impaired hearing. So these are the common symptoms we usually find in cases of basilar artery migraine, and this should be noted, and it's an important clue to let the practitioner know that what he's dealing with is basilar artery migraine. And also it's more prominent in younger women. Younger women, the etiology is not very known, but it is more prominent in younger women. Younger women are more susceptible to have this kind of migraine. And again, triptans are contraindicated in basilar artery migraine. And then let's go forward to the next kind of migraine. It's another kind of migraine called retinal migraine. Retina is the light sensitive layer of the back of the eyes, and it has about 10 layers. So there's what we call the retinal migraine. This type of migraine usually occurs monocularly. So that is the differentiating factor to know that it is what you are dealing with is retinal migraine. Normally, migraine will occur in the two eyes, but when it occurs in just one eye, likely you have a higher chances that what you are dealing with is called a retinal migraine, and usually lasts between 5 to 60 minutes. So in the space of about an hour, those symptoms they experience in migraine, they begin to experience it, and always in one eye. So it is characterized by graying or blackout of vision, also called tunnel vision. So the patient is seeing something with one eye and it appears faded, it appears gray, it appears as if it is going off in just that particular eye, and they notice it when they want to occlude an eye and compare with the affected eye. They notice that that eye is graying, it is occluded, it is graying and it's appearing blacked out. So and lasts for about 5 to 60 minutes. So constriction of the retinal arteries and the venous occurs during this attack, resulting in the loss of the retinal orange color. The normal retinal orange color of the retina is lost during this attack because of the constriction of the vessels. So since the vessels are constricted, it means that the blood supply to the retina is reduced. And if the blood supply to the retina is reduced, there is this pale appearance in that retina. So this is how we know that we are dealing with retinal migraine. And these are uncommon forms of migraine, but then the practitioner should and must be ready to be able to tackle any kind of migraine that comes his way. Another kind of migraine is the type we call ophthalmoplegic migraine. Ophthalmoplegic migraine, as the name implies, ophthalmoplegia, which is a paralysis of or a constriction of the muscle involved, and it usually begins before age 10. It usually found in patients who are less than, or it begins in patients who are less than 10 years, and ophthalmoplegia follows or precedes the headache. So a patient begins to tell you that before I had the headache, I could not move my eyes in a certain direction, or after I had the headache, or while I was having the headache, I could not move my eyes in a certain direction. So it is an important clue to note that what you are dealing with is an ophthalmoplegic migraine. And the pupil is usually involved in half of the cases. People is usually involved. There's a pupillary involvement in half of the cases. And third nerve palsy, the third cranial nerve, which is the oculomotor nerve, is also affected. So we notice a cranial nerve 3 palsy in this case. And also paresis. Paresis is partial involuntary movement, or a partial constriction, or not just constriction now, but partial paralysis of a muscle. So paresis usually resolves after about 1 to 4 weeks. That is within a month. The paresis will begin to wear off gradually. And also the presence of the pupillary involvement and cranial nerve 3 palsy in patients under 10 suggests for MRI. So when we see this cranial nerve 3 palsy, we are seeing pupillary involvement accompanied with headache. In fact, it wants to look like Horner syndrome, and then in that case, it is advised that we send for MRI to know what is going on there. Is there a constriction of a blood vessel? Whatever it is, MRI is the choice of diagnostic test to find out what is actually going on in that case. Also, the treatment plan is usually oral prednisolone. Oral prednisolone is the treatment plan for ophthalmoplegic migraine, but then your doctor is in the best position to know how to administer it, the dosage to give, and how to taper it. So it is the function of the practitioner to form out a treatment plan towards treating that. Also, there's another kind of migraine again, which is an uncommon kind of migraine called benign episodic mydriasis. In this case, you find a dilated pupil, but in the absence of cranial nerve 3 palsy, symptoms of angle closure glaucoma must be ruled out. So when you rule out angle closure glaucoma, and then you are seeing a dilated pupil accompanied with headache, with the absence of cranial nerve 3 palsy, which can manifest as ptosis. So we want to question benign episodic mydriasis. So another kind of uncommon form of migraine seen in the clinic. And also there is another special kind of migraine that is uncommon, but every practitioner should take note of it, and is migraine called migraine in women. So there is a migraine found only in women. That is, even though generally migraine occurs more in women than in men, but there is a migraine called migraine in women. So this migraine is usually attributed to menstrual cycle. So menstrual migraine is associated with menses and lasts longer and is difficult to treat. Usually lasts longer and is difficult to treat. Also, some women also experience migraine during pregnancy, and these medications, except acetaminophen, are contraindicated. So when we see migraine in women during pregnancy, the drug choice is usually acetaminophen, but the doctor is advised to stick with acetaminophen. But then whatever drug he wants to use, he knows best and knows why he wants to use such a drug. So during pregnancy, some women will usually experience migraine more than others, and it's not hook, line, and sinker. I'm not saying that every woman must experience migraine, but it is usually seen in women. And also, oral contraceptive is often discouraged in women as it can increase the risk of ischemic stroke in those of childbearing age. So oral contraceptives are usually we usually discourage women who are pregnant of taking it because of the complications it can induce. So that is that for migraine, the types, and all the uncommon forms of migraine. We want to now look at the diagnostic tests for migraine. When we have what are the tests that helps us to diagnose that what we are dealing with is migraine? Not every headache experience is migraine. So there are tests we want to do, and it helps to guide the clinician, the practitioner in what he's doing. The first test is the visual field assessment. Visual field assessment is usually very, very important, and it's a diagnostic test for people who we are suspecting or people who have already established to have migraine. So we want to know how the visual field looks like. We want to know if it is affected. We want to know if there's a case of hemianopsia. We want to know what is going on in whether there's scotoma. We want to know, and you can't effectively know and quantify it without your visual field assessment. So you find out that the eye practitioner is expedient or is important, is a vital practitioner in the general healthcare system. So he cannot be overlooked, he cannot be kept aside, because he is important and needed in the care of the total man. And again, MRI is the second diagnostic test, and like I said earlier, MRI should be set with caution as it can even trigger more migraine. Also, lumbar puncture is done when suspecting subarachnoid hemorrhage, meningitis, or pseudomotor cerebri. We might want to employ lumbar puncture. It's also a diagnostic test. Also, routine blood workup is helpful in elderly patients, people who are sedimentary. You might not want to do a full blood workup in young people, but people who are elderly and still experiencing migraine, we want to do a full blood workup, want to check their full blood count and several other tests. It is also helps in the diagnosis of migraine. Quickly, let's go over to the treatment plan for migraine. So there is basically two types of treatment plan. The first is the abortive treatment, and the second is the preventive therapy. So in the abortive treatment, we are trying to treat a migraine that is already ongoing, and in the preventive therapy, we are trying to prevent a migraine from reoccurring. So these are the two major types of treatment plan currently in migraine management, where I'm open in research. For sure, research is going on, and I'm sure there will be other better and more approachive way of treating migraine other than what I'm mentioning here. This is why I'm always open for collaboration with researchers. So just in case I'm not up to speed, I'm open for researchers to always give me feedback, and we share ideas together. Nobody is an island of knowledge. Nobody knows it all. But currently, there are two treatment plans. The first is abortive treatment, and it's recommended when attacks occur less than twice a week and are short-lived. So when we see attacks of twice a week of that nature, we want to begin abortive treatment. And then in the preventive therapy, they are included when headaches are more frequent enough to interfere with the patient's daily activities. So a patient who can't go to work, who can't go to school, who can't even sleep because of headache, we want to apply the preventive therapy. And then there are also cases where it can be merged, both the abortive and the preventive can merge together as one, and then we also want to tackle it. So in the abortive therapy, when we are experiencing a headache that is mild to moderate, what do we do? Usually, patients will not see the need to seek medical attention, but patients who are experiencing mild to moderate headaches, they might overlook it and don't want to seek medical attention. And then most times we want to give, in such cases, we want to give NSAIDs, non-steroidal anti-inflammatory drugs. We want to give them And also want to note the contraindications to NSAIDs. So someone who has ulcer, we are careful. So, but then NSAID has been beneficial. Butalfanol nasal spray, somatropin of 20 milligram intranasally is also helpful. And again, somatropin is a type of trypan drugs, and of the dosage of 25 to 100 milligram orally is beneficial. Also, prednisolone of 60 milligram orally is also beneficial. And then also in the abortive therapy, when we experience a moderate to severe kind of headache. So in this kind of headache, the onset is between 15 to 45 minutes, the onset of this migraine. So we want to begin to treat with oral triptans. They are highly recommended for oral triptans. That's the one you take through the mouth. And also a combination therapy of triptans with NSAID is also important, is helpful. There are some drugs that come as 2-in-1, that is both triptans and NSAIDs together, while there are some that are just separate, so you can get the triptan and the oral NSAIDs together. It is helpful in treating in abortive therapy in treating migraine. And also if we have a rapid onset, which also involves vomiting, we want to bypass the oral means of administration and begin a subcutaneous or intranasal administration of triptans. We also so in the cases of vomiting, most times we don't want to go through the oral route because of the first pass effect and all other disadvantages associated with the oral route. So when we have a less rapid onset and a longer duration, usually seen in menstrual migraine, we want to employ the services of slower onset triptans such as frovatripan and naratripan of 2.5 milligram orally. So these are slow acting triptans that are helpful for slow onset kinds of migraine. And also severe migraine in emergency units will require other routes of administration other than oral routes. So when we have an emergency of migraine, it will require all other routes, subcutaneous, intravenous, other than oral routes. So quickly, let me just talk about triptans because I've been mentioning them since the treatment plan. So triptans are the class, or they are the choice of drug used in treating migraine. So, but it is important to note that the maximum single dosage for oral somatropin is 100 milligram. So we shouldn't give more than 100 milligram per day. And again, the dosage for above of within 24 hours should not exceed 200 milligram. For within a 24 hours, it should not exceed 200 milligram. And also, it is contraindicated in patients who have coronary artery disease, in patients with poorly controlled hypertension, patients with cerebrovascular disease, patients who are pregnant, and patients with hemiplegic or bacillar migraine. It is contraindicated in these patients. We don't want to give because of the side effects and the complications associated with them. So over to the preventive therapy of management of migraine. So headache of more than once or twice in a week falls under the preventive therapy, and the headache usually produces a significant disruption in the social life of the patient. So the patient can no longer do the things he used to do before, so the migraine affects his daily life. Also, cases where symptomatic therapy has failed, we want to employ the use of the preventive therapy. Also, elimination of triggering factors is important in preventive therapy. So we want to eliminate those things that are triggering this migraine. For those that it is brown and bright light, they should avoid bright light. Those who are having whose migraine is triggered by loud noise. There are people who like clubbing a lot, or who like going to maybe churches with loud noise. So you shouldn't sit near a speaker, or maybe in a function, you shouldn't sit near the speaker because the loud sound can induce the migraine. So it is important to identify the triggering factors and eliminate them totally. Also, certain foods such as red wine, cheese, chocolate can also induce it. It is important that such a patient should avoid red wine, avoid certain foods that trigger migraine. And also, medications used in this preventive therapy is beta blockers. Beta blockers are one of the medications we use. Beta blockers, calcium channel blockers, antidepressants, and anticonvulsants. So antidepressants are important for patients who who will not be able, who want to sleep but they can't sleep. So it's a kind of it's a drug choice we give for such kind of patients. So beta blockers, calcium channel blockers, antidepressants, anticonvulsants are medications used in the preventive therapy. And then that is that for migraine. So quickly, let's go over to cluster headache. So cluster headache is another kind of headache experienced in the clinic. So we are done with migraine headache. So we are now looking at cluster headache. So cluster headache is a severe kind of headache. In fact, it can even wake the patient up from sleep. It's a headache that is very severe that can wake up the patient, to show you how severe it is. So, and it is predominantly in men. It is more in men, and it occurs in clusters. That is as if the headache is coming from different places and converging at a spot. So that's what we call cluster headache. And one of the common trigger is alcohol. So you find out that people who take alcohol a lot usually come down with cluster headache. So attacks are more shorter than the migraine, and with no vomiting or nausea is experienced, but attacks are shorter in migraine, and it is usually associated with Horner's syndrome. Horner's syndrome is a syndrome that is associated with the triad of ptosis, meiosis, and craniopathy, anhidrosis. That is a partial sweating. You see the lid is droopy, and a constriction of the pupil. So it is usually associated with Horner's syndrome, this cluster headache. So the treatment includes the use of corticosteroids. We use corticosteroid to treat, and also intranasal somatritans and other forms of medication that is best suited for the patient. So that is that for cluster headache. And then another type of headache is the tension type headache. This is regarded as a continuum of the migraine headache. So tension type headache is regarded as a continuation of a migraine headache. The pain is mild to moderate with no aura or vomiting. So in this kind of headache, the patient is not vomiting, no aura, those visual symptoms are not there, and it's often bilateral, and the area of pain is usually over the eyes, on top of the head, the temple areas or occipital area. So these are the areas where most likely areas where the patient experiences pain. So the treatment involves the use of abortive and prophylactic medications for migraine. So those treatments we use for abortive, like NSAIDs, are employed in this. And in cases where treatment is non-responsive, research has shown that stretching exercise is helpful. So in cases where a patient is being given drugs and there is no improvement, most times stretching exercise are helpful. Acupuncture can be employed, and also botulinum toxin can be injected. So these are cases, these are drug treatment plans that are also important when drugs fail to work in tension type migraine. So that is that for today's class. I hope you've learned, and I'm also expecting your feedback. So I also want to learn from you too. So if just in case you have other knowledge I've not shared here, or there are some things I've omitted you feel should be here, please do well to give me feedback. Do well to message me on my email or on the chat box here. Do well to do that, and I'll be expecting your messages. So thank you all for watching. This is part 4. Next week we'll be coming with part 5, and maybe hopefully part 6 or part 5 will be the last session of headache, and we go to another subject of interest. Do well to like, comment, subscribe, and share. As you do this, it's your own way of encouraging me. It's your own way of encouraging my team to tell us kudos, you are doing a good work. Thank you so much. I remain Dr. Wisdom. So long live the healthcare profession. I hope to see you next week. Have a good night and God bless you.